What's up, future nurses? Today we're tackling some challenging questions that will sharpen your test-taking skills and boost your confidence. We'll work through scenarios, analyze the answers with detailed explanations and expert test-taking strategies to help you remain calm and focus on the exam day. Whether it's figuring out how to prioritize care or identifying complications, we're here to bring you closer to earning that RN title. So jump in, take some notes, and ace these questions. And if you love this content, be sure to subscribe and like this video for more NCLEX preparation tips.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions. Practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Let's get started. So we have our first case here. This is an unfolding case, 1 out of 6, and a highlight type of test item. So let's get into the scenario here. It says, the nurse is caring for a 65-year-old female client in the emergency department. And your task this time is to highlight the findings in the emergency department nurse's progress notes and laboratory values that indicate the client's condition is worsening and requires immediate intervention to prevent further deterioration. Emergency department nurse's progress note states at 8 o'clock, client was brought to the emergency department by family due to shortness of breath, productive cough, and lethargy, which worsened today. Chest muscles feel sore from frequent coughing, alert and oriented ×1. Client anxious and diaphoretic, wheezes auscultated on expiration. S1 and S2 present, bowel sounds present ×4. History of mild chronic obstructive pulmonary disease due to a 52-pack year smoking history. No history of dementia or other chronic conditions. At 8:05, vital signs 99.8 degrees Fahrenheit for temperature. Heart rate 110, respirations 26, blood pressure 100/60, saturation of 86% of room air. At 8:06, started oxygen at 2 liters per minute nasal cannula, kept on continuous pulse oximetry monitoring. At 8:15, client reports increased difficulty breathing, stating, "I can't catch my breath." Respirations 30 breaths per minute, saturation 87 on 2 liters per minute nasal cannula. Wheezing louder on auscultation, client appears more lethargic. Blood samples were collected for CBC chemistry blood cultures ×2 and ABGs. Portable anterior posterior chest x-ray was obtained per the healthcare provider's order. At 8:30, client remains lethargic, responding to verbal stimuli but slow to answer. Respiratory rate 28 breaths per minute. Saturation 85 on 2 liters per minute via nasal cannula. Heart rate 110. Blood pressure 98/58. Family reports client has not eaten or drunk much in the past 24 hours due to fatigue. And we have the different lab results. White blood cells 14,000, hemoglobin 12 grams per deciliter, sodium 134, potassium 3.5, blood urea nitrogen 28 milligrams per deciliter, creatinine 1.4 milligrams per deciliter, pH of 7.32, partial pressure CO2 50, partial pressure of oxygen 58, bicarbonate of 26, oxygen saturation of 88%, and lactate of 1.9 milliosmoles per liter. So what do you think the findings that you should highlight here. All right, so I want you to try your best as much as possible here. So one of those findings that you should highlight is this one. We got client was brought to ED by family due to shortness of breath, productive cough, and lethargy, which worsened today. So that's a huge red flag for this client with a COPD. The phrase worsened today, that simply means this isn't their normal. It is a change. And in the emergency department, a change like that screams, I'm having a flare-up. And the shortness of breath means their airways are probably tight or clogged with mucus. The productive cough could be an infection like bronchitis or pneumonia, which is very common in COPD. And lethargy tells us they're not getting enough oxygen to their brain and their body. So this is their body saying, I'm in trouble and we need to jump on it. So we got to get oxygen on, check their lungs, and figure out what's driving this before they're going to tank. Now, what else do we need to check on here? We have the statement, alert and oriented ×1. That is oriented to self only. So the client knows who they are, but not where they are or what's happening. So that's a problem. Normally, we'd want a person to be alert oriented ×4 in the emergency department, or let's say ×3. With a COPD and their shortness of breath, this foggy mental status is likely from the hypoxia because their saturation is 86% a few minutes, or actually, yes, it was 86%. And they're starting to retain carbon dioxide, which makes them confused. And it's stated in the case that the client does not have dementia. So this is not their baseline. It's something new. And that means their breathing has worsened. And it's really affecting the brain function. And what else do we have? We have client anxious and diaphoretic. That's also significant, because anxiety in someone who's short of breath is their body's way of saying, I can't breathe and I'm freaking out. And the diaphoresis that we are seeing is a stress response. It could be from the low oxygen, their heart working overtime, such as the heart rate being 110 at 805. And with COPD, this means they're in distress. And if we don't intervene, their difficulty breathing, this could turn into a panic, and the sweating could mean they're heading towards something worse. Now, what else do we have here? We have wheezes auscultated on expiration. There you go. So this is a classic sign of airway narrowing. So think about bronchoconstriction, which fits their COPD history. And that's why they're short of breath. Their lungs are like, nope, air's not moving out in easy. And with their symptoms worsening today, this wheezing tells us their COPD is flaring up big time, likely from an inflammation going on in the lung fields. Now, what else do we have here? We have heart rate of 110 beats per minute to respirations of 26 breaths per minute. Now, the heart rate that is 110, this is way too fast for this patient. With a COPD, having this saturation and, of course, the heart rate, the respiration of 26, this tachycardia is their heart trying to make up for the low oxygen. So it's like, I'll pump faster to get more oxygen around, but that's already going to cause some strain into the heart, especially with a respiratory rate that is already up at 26 and the blood pressure a bit low at 100/60, even though it's still considered normal. It's a sign they're not doing well, they're hypoxic, and their body's stressed. Now, what else do we have? Of course, 26 respirations, right? It's also above a normal. Normally, it should be around 12 to 20. And they're not getting enough oxygen here. The body's trying to compensate by making the lungs work harder. And they're not actually moving air in and out effectively. So they're trying to compensate by making their breathing faster. But this is exhausting. Now, what else do we have here? We have saturation of 86% on room air. This is way too low. Normally, we're supposed to be at 95 to 100%. And even for COPD, we aim for about 88% to 92%. But this time, 86% on room air, they're hypoxic. And that's why they're having shortness of breath, tachycardia, they're anxious, and their mentation is fuzzy. Now, what else do we have? Let's take a look into the 815 timestamp. Of course, here's that statement. Client reports increased difficulty breathing, stating, "I can't catch my breath." So, that's worse than the shortness of breath that they had at 8 a.m. And so here, they're feeling it more, and that's a big deal. Because with COPD, this means their airways are probably getting tighter, maybe from the inflammation. And take note that the client is already receiving 2 liters of oxygen, but it's still not enough. They're still struggling. So this is their body telling us that they're in deeper trouble and we need to ramp up the interventions. Now, what else do we have? We have the respiratory rate of 30 breaths per minute, saturation of 87. And what else? We have the wheezing louder on auscultation. Of course, this is louder than the previous auscultated sound here, right, at 8 o'clock. And the louder wheezing that we are hearing this time, it simply means their airways are narrowing even more, and the bronchoconstriction is getting worse. It's probably from their COPD flare-up, and that's why they're struggling to breathe and their saturation going downhill. Now we have the next statement. It says, client appears more lethargic. The word more is actually a huge change as well. In someone with this client, more lethargy can actually mean their brain is not getting enough oxygen or they're retaining CO2, which makes them sleepy. And with COPD, this is a classic sign of worsening respiratory failure. They're too tired to keep fighting. What else do we have? Let's take a look into the timestamp at 8:30. It says, client remains lethargic, responding to verbal stimuli, but slow to answer. Now they're slow to answer. Take note of that. Even when you talk to them. They were alert-oriented times 1 at 8 a.m., but this is worse. Their mental status is slipping further. This is a big sign their brain's not happy, likely from ongoing hypoxia. But with a COPD, this is a step closer to a huge problem. If they get too drowsy, they might not be able to protect their airway. So we need to escalate our actions this time. Now, what else? We have, of course, respiratory rate of 28, saturation of 85 on 2 liters, heart rate of 110 beats per minute, and together we have a blood pressure of 98 over 58. Now it is causing the blood pressure to go down as well. So even if it's not a huge drop, it's going on the bad direction. Because with the heart rate still at 110, this could mean they're dehydrated. Family says they haven't eaten or drunk much, or the body's struggling to compensate for the low oxygen. And in someone with a COPD who is already hypoxic, a drop in the blood pressure is a sign they are decompensating rather. And we need to get the fluids in to fix their circulation and also to help with their breathing, because if this keeps trending down, they could go into shock. Now, what else we have? We have here family reports client has not eaten or drunk much in the past 24 hours due to fatigue. So that's a big deal, because fatigue that is bad enough to stop them from eating or drinking isn't just saying, I'm a little tired. It's their body saying, I'm too exhausted to even do the basics. And with COPD, that fatigue ties back to their breathing problem. They're working so hard to breathe, and they don't have the energy for anything else, even to take a sip of water. So this means they're dehydrated and not getting any fuel, which we see with their blood pressure dropping to 98 over 58. and the heart rate still at 110. So with the dehydration, it makes it harder for their body to fight this respiratory issues. It's going to thicken their mucus, it stresses their heart, and it's going to make their fatigue worse. And so we definitely need to get some fluids going into this client. Now let's move forward to the laboratory results here. Obviously, we have the white blood cell count, 14,000. This confirms possibly an infectious process consistent with an inflammation. Could be a pneumonia here. This is contributing to the client's respiratory distress. What else? We have blood urea nitrogen of 28 milligrams per deciliter. So this suggests dehydration and possible early renal impairment, which can worsen the client's overall condition and can also complicate the overall respiratory management. Another is creatinine of 1.4 milligrams per deciliter. This indicates early renal dysfunction, likely due to the dehydration, which can exacerbate the client's systemic stress. And this can also impact the respiratory recovery. And also, we have the arterial blood gases results. Obviously, we have the pH of 7.32. This is indicating respiratory acidosis, which is a critical finding in a COPD patient with pneumonia, reflecting carbon dioxide retention due to impaired ventilation. We also have the partial pressure of CO2 of 50. That's also a red flag. This confirms that there is carbon dioxide retention, which is a hallmark of respiratory acidosis and COPD. And this indicates worsening ventilatory failure. Now, partial pressure of O2, which is also low at 58, supposedly at 75 to 100, this indicates that the client is having severe hypoxemia, which is a critical finding that aligns with the saturation readings, and this increases the risk of a bigger problem. Now, what else do we have here? There's saturation of 88%, right? This actually confirms hypoxemia, which is consistent with the pulse oximetry readings that we've seen in the documentation. And this is a critical indicator of the client's deteriorating respiratory status. Now, let's move into the other findings that are not urgent or doesn't really require immediate intervention. Well, of course, one of those is the chest soreness, right? This is basically not gonna indicate acute chest or worsening condition, even though this is a result to, or a side effect to, the faster pattern in their breathing, but it's definitely not a sign that is complicating their breathing issue. Another is the, what else? We have the temperature 99.8 degrees Fahrenheit. This is not really that significant. It's what we could call as low-grade temperature. This is not really going to call for an action, but we are going to keep monitoring that because this will also increase possibly. And the blood pressure, where's the blood pressure? 100/60 mmHg is not that significant yet, around 805. Now, what else? The other statements right here, like started O2 at 2 liters per minute. This is a nursing intervention. Also with this one, keep on continuous pulse oximetry monitoring. This is an intervention, so this is not really something that you should be focusing about. What we're looking here are the patient manifestations. All right, abnormal assessment findings. Now, what about the hemoglobin here of 12 grams per deciliter? That's on the low end. Remember that our client is a female, right? Usually their range will be around 12 to 15.5 grams per deciliter. So this doesn't really cause any worry this time. On the normal, low side of the normal, but this is not a critical finding that requires immediate attention. The sodium level of 134 is slightly low, right? This indicates hyponatremia, likely due to the dehydration, but this is not a critical finding. The potassium of 3.5, it's on the low side of the normal range. It is not concerning as well. and the sodium bicarbonate of 26 milliequivalents per liter, that's within the normal range on the upper end, and the lactate of 1.9 milliosmoles per liter is also within the normal range. So nothing to worry about that value. So I hope that you're able to get these phrases and lab results all figured out. All right, so let's have our next scenario. This is basically a continuation, and this is a drag and a drop type of test item. And so basically this is the same client, same nurse, and we don't have any new documentation around this side, but let's take a look at the bottom. At 8:32, chest x-ray results showed right lower lobe pneumonia. Now your task this time is to identify the most appropriate choices to complete the statements below. It says, based on the client's shortness of breath and chest x-ray findings, the nurse identifies the priority problem as blank. So we have the options: ineffective breathing pattern, impaired gas exchange, risk for fluid volume overload, impaired tissue perfusion, decreased cardiac output, and acute confusion. What do you think would best match this blank? So I want you to think critically here. So the main problem in this statement is basically impaired gas exchange. Why is that? The client is in respiratory distress. Their shortness of breath, the respiratory rate is 28, saturation at 87 on 2 liters per minute per cannula. And at 9:30, they're saying, I can't catch my breath at 8, like around that 8:15? Yes, 8:15. Now, in COPD here, they might have a higher baseline PaCO2, but this level paired with their increasing lethargy and slow response by 9:30 shows they're not ventilating well. And take a look into the ABGs as well. Again, the ABGs confirm that there is hypoxemia, with the partial pressure of the oxygen being low at 58. They're actually retaining carbon dioxide at 50 mmHg, right? Now, the chest x-ray confirms that there is lower lobe pneumonia, which fills the alveoli with the exudate. It will reduce the surface area for oxygen to diffuse into the blood. And on top of that, their COPD causes the air trapping and hyperinflation, which is already noted in the x-ray. So it's going to make it hard to move air in and out. And so this is going to create a ventilation perfusion mismatch. The client here cannot get enough oxygen in or even out. So we're talking about the carbon dioxide and the exchange of gases here. Now, this is life-threatening because it directly affects tissue oxygenation. Their brain and organs are not getting enough oxygen, as we see with their lethargy. And if this continues, they're at risk for respiratory failure. And so with the NCLEX using prioritization, this aligns with breathing, right? Especially when you're using the ABCs. And the physiological need of, especially with the air, the Maslow's hierarchy of needs, the need for air. So making it the top priority over the other problems like the dehydration or infection. Now let's go through the other options here. Ineffective breathing pattern. Why it's not a good match? Well, remember that ineffective breathing pattern refers to an abnormal rate, rhythm, or deep breathing, or maybe faster breathing, like if they're having irregular or shallow breaths. Well, the client's respirations is 28, which is already tachypnea, and they're actually working hard to breathe, and their breathing pattern isn't the core issue here. It is a symptom of the underlying problem. The real problem is impaired gas exchange because their ABG shows they're not oxygenating, the PaO2 is low, They're also retaining carbon dioxide because of the pneumonia and the COPD. Now, the tachypnea is their body's attempt to compensate for that, but the priority is the gas exchange, not the breathing pattern, because that's what's exactly threatening tissue oxygenation. And this is leading already to their lethargy and the risk of a much worse of a complication. Now, what about the risk for fluid volume overload? Why do you think this is an incorrect statement or incorrect match? Well, this is something that you would be worried if they were getting too much IV fluid or had maybe a heart failure causing pulmonary edema. But this client is dehydrated. And this is reported by the family, right? That they haven't really eaten or drunk in 24 hours. And so that's why their BUN and creatinine levels are elevating. And around this time, they're not at risk for fluid overload. Yeah, they're actually in need of fluids. Now, what about the next one? We have decreased cardiac output. Do you think that this is going to match to the problem? I doubt it. Well, decreased cardiac output is something that you would worry if the client may have a history of heart failure. Whenever the problem is with the ventricles not able to pump the blood effectively. And take a look into the blood pressure of 98/58, right? And the heart rate that is high, 110. That is more likely related to a dehydration, not a primary cardiac issue. And take a look into the S1 and S2. Where is that? S1 and S2? Yes, it's right here. This is basically ruling out that decreased cardiac output because it's not really supporting a case of failure in the ventricles, right? Now, what else do we have here? We have acute confusion. Do you think acute confusion would be an issue here? Is this really going to be a priority issue? Well, the acute confusion could be a symptom of their condition. They're lethargic, they're slow to respond by 9:30, which might look like confusion. But this is likely due to the hypoxemia from the impaired gas exchange, and the brain is not getting enough oxygen, causing the lethargy. And again, the confusion is a result to the gas exchange problem, not the priority problem itself. Now, impaired tissue perfusion, I think I must have missed this one. The impaired tissue perfusion is simply telling us that organs are not getting enough blood flow due to the low cardiac output or poor circulation, right? But the primary cause is respiratory. There is impaired gas exchange from the pneumonia and COPD causing hypoxemia. And the poor perfusion might be a secondary concern due to the dehydration, but the root problem is the inability to oxygenate their blood, and it's not a circulation issue. So, yeah, you can consider this, but not really the most priority problem. Now, let's proceed to the next sentence here. It says, the nurse determines that the primary cause of the client's impaired gas exchange is blank. And we have the options: COPD, right lower lobe pneumonia, hypovolemia, anemia, and tachycardia. What do you think would be the best fit here? Well, it's actually asking us to give the reasoning why the client has impaired gas exchange. And so the answer here is the right lower lobe pneumonia. Since it's already confirmed by the chest x-ray, and that's the main driver of the impaired gas exchange right now. It causes consolidation, so those alveoli in the right lower lobe are filled with exudate. We're talking about pus, fluid, inflammatory cells, which actually block the oxygen from diffusing into the bloodstream. And so this is going to lead to ventilation perfusion mismatch, and the affected area is ventilated but not perfused with oxygen because the alveoli are clogged. It's causing their PaCO2 to drop to 58, and also the saturations to stay low at 87%, despite giving the client 2 liters per minute via nasal cannula. And so with the productive cough that is worsening today per the documentation at 8 o'clock, and also the elevation of the white blood cell count of 14,000, this support an active infection, and the pneumonia is what's acutely worsening the gas exchange on top of their chronic COPD. And also, the COPD contributes to the overall respiratory compromise, but the pneumonia is it's the acute issue that is directly causing the drop in the oxygenation, and this increases the CO2 retention we are seeing in this patient. All right. And the lethargy and the respirations being high at 28, it shows how this is impacting their ability to oxygenate. So it's going to make pneumonia the primary cause of their impaired gas exchange at the moment. Now, what about the chronic obstructive? Yes, that's already what we were talking about, right? The COPD is definitely contributing to the impaired gas exchange because it's their chronic condition, right? Remember about the 52-pack year smoking history? They likely have emphysema, which destroys the alveoli and causes air trapping. And this is going to make it harder to move air in and out, leading to a baseline level of impaired gas exchange. But the primary cause of their current worsening gas exchange is their right lower lobe pneumonia. Alrighty. Now, what about hypovolemia? Why do you think this is incorrect? Well, we know that hypovolemia is low blood volume and this client is dehydrated. Family reports no eating or drinking for 24 hours. Now, the hypovolemia can affect tissue perfusion by reducing the blood flow, but it's not the primary cause of impaired gas exchange. Their gas exchange problem is from the lungs, which is caused by the pneumonia, which is blocking the oxygen diffusion in the right lower lobe, and the COPD is making the ventilation harder, as we are seeing with the ABG results. Now, hypovolemia might worsen their overall condition by reducing oxygen delivery to the tissues, but the root issue is in their lungs, not their blood volume. And take note that pneumonia is the direct cause of their gas exchange impairment. Now, what about anemia? Why is this incorrect? Well, the anemia could contribute to impaired gas exchange if their hemoglobin was low. But take a look into their level. It's 12, right? It's within the acceptable range. And so this is irrelevant in this case. Now let's go into the tachycardia. Why is this incorrect? Because the tachycardia here, it could be due to the dehydration and as a compensatory mechanism to hypoxemia. The tachycardia can be a response to impaired gas exchange. The body is trying to compensate for low oxygen by pumping the blood faster, but it's not the cause of the gas exchange problem. Again, the primary cause is their lungs, the pneumonia, which is blocking oxygen diffusion in the right lower lobe. And so for you to answer this question correctly, I want you to use the ABCs in prioritizing the problem. All right? Again, the ABCs is a go-to NCLEX strategy for most of the priority questions. So when you're asked to identify the priority problem, especially in this case, always think, is there an issue with the airway? Is there an issue with the breathing? Or is it the circulation issue? And in the NCLEX, it's going to give you a mix of actual and potential problems in so many client scenarios. But when you're prioritizing, you have to take priority on the actual problems over potential problems, unless the potential problem is immediately life-threatening. All right? So don't forget that. Also, look at the options for the blank one. Most are actual problems. Remember, there's ineffective breathing problem, impaired gas exchange, impaired tissue perfusion, there's decreased cardiac output, acute confusion. So these are active problem except for the risk for fluid volume overload, right? So this is a potential problem. The risk for fluid volume overload is a potential problem. The client is, of course, showing they're dehydrated with a BO and creatinine showing the in the labs, and the client here is not overhydrated, but rather dehydrated. So it's not really relevant here. Now, I want you to eliminate those options that don't fit the client's data, especially for blank 2. Eliminate those options that don't match the client's manifestations here, such as the hypovolemia. There's that anemia, tachycardia. So these are not really coinciding with what is really going on or what's causing the impaired gas exchange. So I want you to go back into this test question if you did not get the second sentence correct. And so go back into the concept of the oxygenation and also the fluids and electrolytes. All right. Alrighty, let's move forward to our next question. 3 out of 6, the same client. We have the same nurse's progress notes, nothing new in the documentation. The last documentation that we are seeing is chest x-ray results showed right lower lobe pneumonia. All right, let's review. We have the provider orders. It says place and maintain peripheral IV, normal saline 500 mLs, IV bolus now, then start IV 0.9 normal saline infusion at 75 mLs per hour, CBC and comprehensive metabolic panel, lactate level, blood cultures ×2, albuterol 2.5 milligrams inhalation ×1 dose now, methylprednisolone 60 milligrams IV ×1 now, portable anterior posterior chest x-ray, administer ceftriaxone 500 milligrams IV ×1 now, BiPAP with settings IPAP 12 cm water, EPAP 5 centimeter water, respiratory rate 12 breaths per minute, FiO2 40%, monitor saturation continuously and titrate FiO2 to maintain saturation of 88 to 92% and obtain ABG 1 hour after BiPAP initiation. So those are the healthcare provider orders. So let me just check real quick into the documentation. So this is actually an order that was placed 8:15, not 8:30. So let me correct that one. All right, that's 8:15. All right, let's go back into that one. So we have a case of, okay, before we go do that, looks like we need to review the lab values to see if there's anything new. We have the same white blood cells, hemoglobin, sodium, potassium, blood, urea, nitrogen, creatinine, lactate, ABGs. These are the same values. So we have our Bowtie question right now. And so your task is to complete the diagram by selecting from the choices below to specify the most critical complication the client will experience, 2 nursing actions that are appropriate to take, and 2 parameters to monitor the effectiveness of nursing actions. So We have our potential complication, 2 nursing interventions, and parameters to monitor. So what do you think would best fit our potential complication as you have reviewed in our documentation, the labs, and also the ABGs, of course? So what do you think would be the most significant or critical complication? Well, of course, no other than the respiratory failure. This is a client that has a long-standing history of COPD, right? And they presented to the ED with a saturation of 86% on room air, respiratory rate of 30 breaths per minute. There's wheezing, shortness of breath, and of course, these are classic signs of COPD exacerbation. And the chest X-ray showing right lower lobe pneumonia, there's consolidation. This can worsen the hypoxemia by impairing the gas exchange. And going back into the labs here, we have the white blood cell count of 14,000. That is quite high for this client. So this also supports an acute infectious process. And also with the saturations being low, the respirations being high, this is the most life-threatening complication for this patient. Now, why is arrhythmia, or let's say, yes, arrhythmia, an incorrect option here? Arrhythmia. Do you think arrhythmia would be a fatal complication here? Well, take a look into the electrolytes. The potassium level is 3.5. It's on the normal side. And the sodium of 134, hyponatremia, very mild. And so this is less likely to cause any arrhythmias at this stage. And there is no indication that the client is having irregular pulse, or there is no evidence that there is a problem with their EKG. So this is something that you should discard. So eliminate arrhythmia. Now, take a look on acute kidney injury. Do you think acute kidney injury would be a high priority here? Well, basing on the creatinine 1.4 and the BUN of 28, of course, this supports a possibility that there is AKI going on because of the client's dehydration, right? The client hasn't had any good fluid intake in the past 24 hours. Remember that. All right. But do you think that the acute kidney injury would be much of a priority compared to the respiratory failure? I doubt it, right? And so take a look into the blood pressure as well, 100/60. There was also a slight drop in the blood pressure at around 930. This could affect some blood supply to the kidneys, but this is not going to be our most priority problem here. Now, what about fluid overload? Do you think fluid overload would be our priority? Of course, I've already said this in the previous test item. This is something that can happen if the client is getting excessive IV fluids. But again, our client is the exact opposite. Our client is dehydrated, right? And there's no mention that they have some issue with their pumping ability in their heart. So we're going to eliminate that as well. Now let's move on into the nursing interventions. What do you think would be the 2 interventions that would be so applicable here? One of those is to contact the respiratory therapist to administer nebulizer treatment with bronchodilator. Well, this is a spot-on intervention because this is going to address the wheezing that has been going on at 8:15, right? It simply means that their airways are narrowing, and there's also classic bronchoconstriction going on due to the COPD flare-up. And remember that with COPD, the airways are already inflamed and prone to spasms. And of course, with the ongoing infection, it's going to make it worse by adding more mucus, and it will also irritate the airways. Now, we definitely need that bronchodilator. Of course, with the administration by the respiratory therapist, this is going to relax those airway muscles fast. It's going to open them up so they can breathe easier. Now, what else do we have here? we are going to prepare the patient for BiPAP use. And why do you think this is very important? Well, take note that the client has already been receiving 2 liters of oxygen via nasal cannula, and the client is not improving at all. And the client is showing significant respiratory distress. The client's respiratory rate is in the high 20s. I think there was one thing about 30 cycles per minute. They're also saying that they cannot catch their breath. There's also worsening lethargy. So this is screaming risk for respiratory failure. And again, with the COPD patients, they often get exhausted from the work of the breathing, especially during an exacerbation with an infection like pneumonia, which is actually worsening all the entire case. Now, why BiPAP is one of those interventions? It's going to provide 2 levels of the pressure, wherein there's going to be higher pressure during the inhalation to help the client breathe in, and lower pressure during exhalation to keep the airways open. And that's the reason why the BiPAP is going to help. This will reduce the client's work of breathing, and this will also improve both oxygenation and the clearance of carbon dioxide. And so when you are preparing the patient for BiPAP placement, simply means getting the equipment ready and also explaining the mask to the client, since it can feel claustrophobic, and also to ensure they're positioned comfortably to tolerate it. And so this is a step up from the nasal cannula that we are giving them, because this can really prevent intubation by supporting their breathing while we treat the underlying issues like the pneumonia and the bronchospasms. And so with COPD, we're going to aim for at least a saturation of 88% to about 92%. This is the realistic range that we should achieve. And the reason for that is to avoid suppressing their respiratory drive. But with BiPAP, they're going to get more oxygen in, and this is going to help clear more CO2 to improve their level of mentation. Now, why is this option incorrect? Administer O2 at 4 liters per minute via nasal cannula. Well, obviously, the client has a history of COPD, right? They're not supposed to get anything higher than 2 liters this time, because their saturation is already low at 2 liters. And if we're going to deliver more O2, then this is not going to do them any good. This can suppress their drive. This can lead to hypoventilation. There's going to be more CO2 that will be retained in their lungs. This can worsen their respiratory failure. And again, when we are going to increase their the oxygen delivery, this can overshoot the CO2 level as well. This can cause narcosis, especially that they're already lethargic. They're slow to respond. And this intervention will not really address of what is going on. Now, let's go into administration of IV lactated ringers solution. Why is this incorrect? Well, when you administer this, do you think that this is going to target the problem of respiratory failure? We know that the client is dehydrated, right, per the family's report. This is something that will rehydrate the client. This will help improve the blood pressure. It will help support perfusion. But in the context of this test item, we are wanting to meet the needs of this patient, which is respiratory failure, right? We are going to select those interventions that will address that possible complication. So administering the lactated ringers will not help. Okay, it will help the possible complication, the other possible complication, which is dehydration. Now, what else do we have? Administer IV broad spectrum antibiotics. Why is this incorrect? Well, we know that the client has right lower lobe pneumonia. There is an infectious process. This is a good intervention, but this is not going to address the respiratory failure itself, right? The antibiotics will take hours to start working, We know that this is critical for the long-term treatment of the infection, but this will not directly improve their breathing or oxygenation in the next few minutes. What we need for this client is the nebulizer, the bronchodilator, and of course with the use of that BiPAP. All right, and take note that the anti-infective here is geared towards treating the infection, right? It's not going to really target the respiratory failure. Now, what else do we have? Looks like we have an option position the client in a low Fowler's position. This is incorrect. Remember that the client is already hypoxemic, right? And so low Fowler's position cannot facilitate maximum lung expansion. We definitely need to elevate the client's head of bed some more to optimize lung expansion and also to reduce the pressure on their diaphragm. Especially in this client that has COPD exacerbation, we are going to place them in high Fowler's position or possibly orthopneic position, have them lean forward with arms supported on the table, and this was going to ease their breathing as well. All right. Now, what about, I think we have already covered everything here. Now, let's go into the parameters to monitor. What do you think would be the parameters that you can use in the list? Well, one of those is, of course, the saturation levels, right? That's very important. This is our priority so that we can track, we can monitor if the interventions that we are providing to our patient is effective, and to also check if the client's oxygenation is improving itself. And our target for this client is at least 88% to 92% to avoid hypercapnia while we are correcting the hypoxemia. What else do we need to do here? We are going to select level of consciousness. Why do you think level of consciousness is significant? Remember about the client's lethargy, and they are becoming more lethargic as the time goes by. As the saturation went down? Yes, the level of consciousness is a good indicator about the oxygenation. The client's confusion, the agitation, the worsening lethargy are indicators of respiratory failure. The client already presents with a lethargy as soon as they came into the ER, right? And the intervention of oxygen therapy aims to improve oxygenation to prevent further hypoxia. And so when we are monitoring the level of consciousness, this is going to directly assess where the oxygen therapy is preventing hypoxia, right? So again, we are going to see if there is an improvement in the oxygenation to the brain. This is very huge. Now, what about the blood pressure? Do you think that this is going to be a good parameter for the interventions that we are giving to the client? Not so. Even though it can be used with the other interventions, this is not going to be the best fit for the interventions. This is going to be more relevant, especially if we are targeting about dehydration at this point. But since our priority problem is respiratory failure, this is going to be placed in the back burner. Okay. Now, what about the temperature? We know that the client has a low-grade temperature earlier of 99.8 degrees Fahrenheit. There's also that elevation of the white blood cell count. This confirms that the client has an infectious process, pneumonia. Now, the temperature is not directly related to the complication of respiratory failure due to hypoxemia or the interventions of oxygen therapy and the bronchodilator treatment. The temperature is more relevant for monitoring the infectious process, not the immediate respiratory risk. Now, take a look into the urine output. Why do you think this is not the best fit? We know that the client is dehydrated. The BUN and the creatinine levels are already elevated. However, this parameter is not directly related to the complication of respiratory failure due to the worsening hypoxemia or the interventions of oxygen therapy and bronchodilator treatment. This is much more relevant for monitoring dehydration or the risk of acute kidney injury, which is a secondary concern in this case. The same thing with skin turgor. We know that the client is probably bad with as far as skin turgor because they haven't been taking anything in the past 24 hours. But this parameter is not directly related to the complication of respiratory failure due to hypoxemia or the interventions of oxygen therapy and bronchodilator treatment. And so, for you to answer this question correctly, I want you to focus again on the ABCs. The primary issue is respiratory failure. Again, go back into the ABCs. This is going to help you prioritize airway and breathing over circulation or other concerns like dehydration. And of course, when you are selecting the potential complication, you have to go back into the scenario. Do not neglect the key issues that you have found. Now, for the interventions, you have to make sure that you're selecting those actions that will address the airway and breathing first, such as administering contacting the RT for bronchodilator and also preparing the client for the BiPAP use, because this is going to help open up the airways. This is going to get rid of the excess CO2 retained in the lungs. This is going to allow better exchange of gases. And also with the case here, you have to identify the most immediate and life-threatening complication. Again, our client is already dying from the hypoxemia. Remember about the 85% on 2 liters. There's louder wheezing, the mentation being the client is more lethargic. So this is really a sign that the client is going into much more worse complication. Let's move forward to our next test item this time. So here we have the same client. No new documentation. The last documentation here says chest x-ray results show the right lower lobe pneumonia. So your task this time is, for each finding listed below, determine if it is consistent with the health conditions of COPD, pneumonia, or pneumothorax. Select all that apply by placing a check mark in the appropriate columns for each finding. So we have assessment findings: shortness of breath, productive cough, lethargy, chest muscle soreness, wheezing on expiration, saturation 85% on 2 liters per minute via nasal cannula, respirations 28, elevated white blood cell count of 14,000, right lower lobe consolidation. So we have the following columns: COPD, pneumonia, and pneumothorax. So what do you think about the first finding? Do you think that the shortness of breath is something that you can assign for all 3? Yeah? Of course. The shortness of breath is a hallmark symptom of COPD, especially during an exacerbation. It's because of the air trapping and the hyperinflation, and this can reduce the airflow. It's going to make it hard for the client to exhale fully, leading to dyspnea and tachypnea. And the client saying, I can't catch my breath at 8:15 aligns the COPD flare-up. Now, what about pneumonia? Yes, that's also correct, because the pneumonia can cause shortness of breath because of the consolidation in the alveoli, especially the right lower lobe in this case. They're filled with exudate. It can impair oxygen diffusion. This can lead to hypoxemia. Of course, the partial pressure of O2 is 58, and the client is short of breath with a respiratory rate of 28 and saturation of 87%. Now, what about pneumothorax? Do you think that shortness of breath is also manifested in this? Yeah? Yes, of course. When the client has a pneumothorax, even though the client does not have pneumothorax in this case, but this is something that can also be seen in a collapsed lung because of the reduced lung volume on the affected side. This can decrease the oxygenation. Now, let's just put it this way. If this client had a pneumothorax, their saturation of 87% and respiratory rate of 28 would be consistent, because the collapsed lung would also impair gas exchange, leading to dyspnea. So all 3 of these conditions will show shortness of breath. Now, what about productive cough? Is this something that can result to, is this something that can also be assigned to all three? For the COPD, you think so? Yeah. This can cause productive cough, especially during an exacerbation. This is something that is common due to the chronic airway inflammation and mucus hypersecretion, and the client's history of COPD with a 52-pack years smoking and their productive cough that is worsening today are already consistent with a COPD flare-up, and this is often triggered by the infection. The same thing with the pneumonia. It is also going to be checked because typically the pneumonia presents with a productive cough because the infection causes inflammation and exudate in the alveoli. This can lead to mucus production. And of course, the client has productive cough along with the right lower lobe consolidation as seen on the x-ray. So this aligns with the pneumonia as the infection fills the alveoli with the pus and the fluid. Now, what about pneumothorax? Well, unfortunately, this is not going to be assessed in a pneumothorax. It's because with a pneumothorax, it doesn't typically cause a productive cough. It's a mechanical issue. There's air in the pleural space, especially in the collapsed lung. This can lead to shortness of breath and chest pain, but not mucus production. This is this client's cough is due to the COPD and pneumonia, not pneumothorax, which is not supported by the x-ray. Now, what about lethargy? Lethargy? Is this something that you will see in 3 cases? Let's take a look. Yeah, lethargy is common in COPD due to the hypoxemia, the retention of carbon dioxide leading to CO2 narcosis, and of course the slow responses, worsening pH. There's 7.32 rather. It suggests that their brain is not getting enough oxygen and there is carbon dioxide buildup, which is causing the client's lethargy. Now, what about pneumonia? Do you think that lethargy is seen in pneumonia? Yes, because of the systemic effects of the infection, hypoxemia, and also an impaired gas exchange. Now, for pneumothorax, this can also cause lethargy if the pneumothorax is severe, and it can also reduce the oxygenation similar to the hypoxia, or this can cause hypoxia as well. And if the client has had a pneumothorax, their lethargy could be explained by a decreased oxygen delivery as well, especially if the collapsed lung is significant enough to impair gas exchange. But then again, it can be seen in a case of a pneumothorax. So what about the chest muscle soreness? Is this something that would be a significant finding in all 3? Well, with the COPD, yeah, that is also correct. The soreness is going to happen because of the use of the accessory muscles, the intercostals, and also the sternocleidomastoid muscle. They are going to be overused to compensate for the airway obstruction, leading to fatigue and soreness. And of course, the client has reported that they're feeling sore from frequent coughing at 8 a.m., right? Now, what about pneumonia? Do you think that this can lead to chest muscle soreness as well? Yes, due to frequent coughing and increased respiratory effort. And the infection in the pneumonia also can lead to productive cough, which strains the chest muscles, and the respiratory rate of 28 also indicates that they're working hard to breathe, which can also contribute to the soreness. Now, what about pneumothorax? Do you think that this can lead to chest muscle soreness? Well, no, because typically the pneumothorax can lead to sharp. It can lead to unilateral chest pain on the affected side due to pleural irritation, not muscle soreness from overuse. And take note that in this case, the client's soreness is from coughing and a breathing effort, which actually aligns both pneumonia and the COPD. Now, what about wheezing on expiration? Do you think that this is shared between the 3 conditions? Well, for COPD, yes. Wheezing is a classic sign of COPD, especially on exacerbation. It's caused by the narrowed airways from the inflammation, mucus accumulation, and bronchoconstriction. This is going to lead to turbulent airflow on exhalation. Now, what about pneumonia? Do you think pneumonia can cause wheezing? Well, no. Typically with pneumonia, it doesn't cause wheezing. It can lead to the crackles, rales, because of the fluid buildup in the lung fields. For pneumothorax, it doesn't do that as well. It doesn't cause wheezing. What it's going to do is to decrease the lung sounds. It will probably cause absent breath sounds on the affected side due to the lung collapse. And the client in this case scenario has wheezing due to the narrowing of the airways because of the COPD. Not about pneumonia and not about pneumothorax. Now take a look into the next option here. We have saturation of 85% on 2 liters per minute nasal cannula. Do you think that this is going to be shared between the 3? For COPD, yes, this is going to make the saturation low because of the chronic air trapping and impaired gas exchange. And again, with exacerbation, this can be worsened as well. And the same thing with the pneumonia. This can cause low carbon dioxide level because of consolidation of mucus in the lung fields. This can impair oxygen diffusion and can cause hypoxemia as well. The same thing with the pneumothorax. This can lead to reduction in the lung volume on the affected side. So will also affect the oxygenation. That's why there's going to be low saturation. Now for the respirations of 20 breaths per minute, do you think that this is shared between the 3? Well, for the COPD, this is going to be correct. Because with elevated respiratory rate in a COPD, this is a compensatory mechanism for hypoxemia. For pneumonia, this is also going to be assessed as well. Pneumonia can cause tachypnea due to hypoxemia from impaired gas exchange. And the same thing with pneumothorax. This can lead to tachypnea because this is the body's attempt to compensate reduced oxygenation from the collapsed lung. And again, if this client has had a pneumothorax, their respirations of 20 would be consistent because they'd also breathe faster to maintain the oxygen levels. Now let's go into the elevated white blood cell count of 14,000. Do you think this is going to be shared between the 2? Well, apparently not. This is only going to be seen in a client that has pneumonia, a client sign that there is bacterial infection, and this aligns with the chest x-ray that is already done. Now, what about COPD? Why it doesn't cause elevation of white blood cell count? Well, we know that COPD exacerbations can be triggered by infections, which may elevate white blood cell count. But leukocytosis is not a primary feature of COPD itself. It's usually from a secondary infection like pneumonia. And this client's elevated white blood cell count is due to their pneumonia, not COPD. What about pneumothorax? Of course, it's also not going to lead to white blood cell count elevation because this is a mechanical issue. It is not an infection, so it doesn't typically cause leukocytosis. Now, what about right lower lobe consolidation? Well, we don't have any other option here. The correct answer here is for pneumonia alone. This is a hallmark of pneumonia. It indicates that there is filling of pus fluid into the alveoli due to the infection. And this is already confirmed by the x-ray. And for COPD, this can lead to hyperinflation and air trapping on x-ray, not fluid consolidation, because we know that consolidation itself is specific to pneumonia. All right, the alveoli are filled with fluid. With COPD, what you're going to see is hyperinflation. There is distension of the air sacs because the body or the lungs is not able to effectively get rid of the CO2. Now for the pneumothorax, this is only going to show air in the pleural space when it's evaluated through an x-ray. There's going to be visible lung edge there's no long markings in the area. There's no consolidation. And that's why pneumothorax is not one of the problems that will have right lower lobe consolidation. Again, consolidation is specific to pneumonia, not COPD, not pneumothorax. Let's move on to a next item. So we have our question 5 out of 6. Now let's look into the ED nurse's progress notes. This is a brand new documentation. It states at 9:45, client remains in the ED awaiting progressive care unit bed. Respiratory therapist initiated BiPAP at 8:35 with settings IPAP 12 cm water, EPAP 5 centimeters water, respiratory rate 12 breaths per minute if IO2 40%, Solumadril 60 milligrams IVP was administered at 8:40 as ordered for COPD exacerbation and pneumonia. Ceftriaxone 1 gram IV started at 8:40 per provider order for pneumonia. Client reports slight improvement in breathing but states, "I'm still so tired." Responding to verbal stimuli with delayed answers, oriented only to person, lethargic. Family notes client is not himself. Wheezing reduced in expiration, but breath sounds remain diminished in right lower lobe. Saturation 90%. Respirations 24. Heart rate 108. Blood pressure 98/58. Temperature 100.4 degrees Fahrenheit. Skin dry. No urine output since arrival. IV saline bolus 500 ml started at 8:35. And we have a new result in the ABGs. So I want you to compare into the results. At 8:15, these are the original results that we have seen previously, and these are the new ABGs. pH of 7.3, CO2 48, O2 at 62, bicarbonate 25, and 90% saturation. Now your task this time is to choose the correct actions for each bodily system listed below. So we have neurologic, respiratory, acid-base balance, and select all that apply within each group. So what do you think about the neurologic system? You have options: perform a Glasgow Coma scale, elevate the head of the bed to 30 degrees, administer a sedative to reduce anxiety, initiate seizure precautions, assess pupillary response to light. Now, do you think Glasgow Coma scale would be critical here or would be helpful? What do you think? Yes, because the client is lethargic and disoriented, and they respond slowly to verbal stimuli at 9:15, showing that there is a decline in the mental status. And also take note about the worsening pH of 7.3. There's also high carbon dioxide of 48, even though it went down 2 points. But it still suggests that the client still has respiratory acidosis that is still affecting the brain. It's reducing the client's alertness. And we know that with Glasgow Coma scale, it measures eye opening, verbal response, motor response to evaluate consciousness. And so this assessment is a priority because it monitors how the respiratory problem impacts the client's neurologic function, and this can help the nurse decide if urgent action is needed. Now, what about elevate the head of the bed to 30 degrees? Do you think that would be it? So before we go to that, the next correct answer here is assess pupillary response to light. Well, why? It's because the client's pupil response and reaction will test the brainstem function quickly. Again, the reason that we're doing pupillary response monitoring is to check for brainstem function. And take note that the client has lethargy, disorientation at 8:15 up until now, along with the O2 level of, 62 mmHg. There's also worsening pH. This indicates that there is poor oxygen delivery. There is also carbon dioxide buildup, which may be affecting the brainstem. And this assessment is a key action to spot any serious neurologic changes caused by respiratory issues, and also to check if the BiPAP has already is doing anything good for the client as well. And so that's why pupillary reaction is also key nursing intervention to monitor for that one. Now, why is elevation of the head to 30 degrees incorrect? Well, we know that 30 degrees is not enough, right? For this client, definitely our client will need upright position. This is not going to help the prevention of aspiration. Remember that the client is already much more lethargic, even though they're responsive, but this is not going to maximize the lung expansion. This is not going to improve the ventilation due to ventilation that will also fix the worsening pH. So this is not going to be an ideal nursing action. Now, administer a sedative to reduce anxiety. Do you think that this is a good intervention? Of course not. When you are going to administer a sedative, this is going to slow the client's breathing further. This can cause retention of carbon dioxide. There's going to be narcosis, and this is unsafe for this client who's already lethargic. Of course, no sedative for a patient that is already lethargic. Now, what about initiate seizure precautions? Well, for this client, there are no signs of seizures, or they're not at risk for seizure at all. The drowsiness and disorientation are due to the low oxygen and high carbon dioxide, not a seizure disorder. And so taking seizure precautions doesn't address the respiratory cause of the neurologic changes, and it also wastes time when assessment is more urgent. Now let's take a look into the respiratory system. What do you think are the answers here? Well, of course, we are going to select collaborate with the respiratory therapy to improve ventilation. Remember about the low O2 levels. I'm talking about the saturation and the ABGs itself. And take note that we nurses cannot change the BiPAP settings. We're not allowed. Only the respiratory therapists are allowed to do changing of the BiPAP. But when we are working with them, when we collaborate with them, they can adjust the pressures according to the prescription to boost the ventilation. And this is a priority action to fix the patient's respiratory acidosis, which caused the client's pH to drop. And also, this is going to prevent worse breathing issues. Now, what about discontinue NIPPV and return to nasal cannula? Well, NIPPV is the non-invasive positive pressure ventilation. So are we going to discontinue? Of course not. This is a bad intervention, and this is going to remove the current ventilatory support of the patient. This could make the oxygen levels drop even more, and this could also cause more acidosis into our patient. So that's why we are not selecting this one. Now, what about suction the airway to remove secretions? Well, the client has reduced wheezing at 9:45 a.m. and there are no signs of blocked airways needing suction. The main issue is poor ventilation. There is pH of 7.30, the carbon dioxide of 48. It's not about secretions. And so if you're going to do suctioning here, this could place more stress on the client's breathing even more, especially they are drowsy, and it's not going to fix the underlying problem compared to improving the non-invasive positive pressure ventilation. And so only one for the respiratory system. Now let's look into the acid-base balance. What about this one? Ensure proper non-invasive positive pressure mask fit. I'm talking about the BiPAP right now. And so take a look into the pH again of 7.30 and the partial pressure of carbon dioxide of 48 at 9:35. It shows that the non-invasive positive pressure ventilator is not working fully yet. It's possibly due to a loose mask that's letting air leak. And so a proper mask fit will help ensure the set pressures are delivered properly to clear the carbon dioxide and also to improve the pH. And so this is your job to make sure that the mask is fitted properly into the client's mouth and the nose. This is your key step to fix the acid-base imbalance without waiting for any other orders. Now, what else are you going to do here for the acid-base balance? You're going to notify the healthcare provider of worsening pH. Why? Take a look into the pH again. From a pH of 7.32 to 7.30, even though that is a small drop, or the worsening here is a little bit, but it still indicates that there is respiratory acidosis that is not resolving with the current treatment, especially that the client has already received the albuterol and the BiPAP. And if the pH continues to drop, the client is at risk for worsening respiratory failure, which is already their most critical complication. However, the partial pressure of the carbon dioxide has decreased from 50 to 48. This is a small improvement in ventilation. This is likely due to the BiPAP itself and the administration of albuterol. But these are minor improvements. And looking into the PaO2 of 62 from 58, this is showing better oxygenation, which makes sense, of course, with the use of the BiPAP and the bronchodilator that was given. But look into the bicarbonate that is going 1 point lower from previous value of 26. So this is a slight drop, not really a big change, and still suggests that there is a minimal compensation. And so when you have a patient that has COPD exacerbation, a dropping pH can lead to carbon dioxide narcosis. This is going to cause lethargy. This can lead to respiratory arrest or possibly the need for actual intubation, which we want to avoid due to the weaning challenges in COPD patients. And so what we are basically doing right now is to prevent a much more invasive type of ventilation. And so here, your task is to be responsible for monitoring the client's treatment and also to advocate for the client's well-being. So we need to make sure the client's physician is aware about the last or recent lab results, especially the ABGs, and also the ongoing state of the client. And specifically, the medical provider has ordered a follow-up ABG lab value after the initiation of the BiPAP. So this is a very significant medical order that we should not fail to communicate to the medical provider as well. Now take a look into the other option, administer sodium bicarbonate IV. Do you think that this is appropriate? Well, sodium bicarbonate is something that we administer to clients who have metabolic acidosis, not respiratory acidosis. And in this case, this can actually raise the CO2 levels, which could worsen the problem in this case. And this is also not ordered in the, it was not ordered by the provider also. Now, what about the increase IV fluid rate to 200 mLs per hour? Is this something that you should do? Well, take note that the client is currently receiving IV normal saline bolus at 500 mLs, which was started at 835. And take a look into the previous order. The client will be receiving 75 mLs per hour once the bolus is complete. And again, this is going to help address the dehydration. And so, again, the administration of IV fluid will help address the dehydration, but it will not improve the acid-base imbalances, especially that there is CO2 retention. And if we're going to administer 200 mLs for this client, this could possibly lead to fluid volume overload, and which we don't want to do. Now let's look into our next scenario. 6 out of 6, the same case. Now the client is transferred to the progressive care unit. So let's take a look into the case. At 11 a.m., patient arrived in room P002 from ED on BiPAP. Lethargy persists, slow to respond on continuous cardiac monitoring. Wheezing is reduced on expiration. Crackles are auscultated in the right lower lobe. IV fluids infusing. We have saturation of 91%, respirations 24, heart rate of 106, blood pressure 102/62. Lethargy persists, no urine output since 0800. At 12:30, teaching provided on BiPAP, IV fluids, and antibiotics. Client statements are recorded to assess understanding. Your task this time: for each client statement below, click or specify whether it indicates understanding or no understanding of the teaching provided about their current treatment upon transfer to the progressive care unit. So, let's review each statement this time. Alrighty. So, the first one states the mask pushes air in to keep my lungs from collapsing. Does this mean that the client has understood or not understood the teaching? It says the mask pushes air in to keep my lungs from collapsing. This is a statement that does not show understanding. Why? This is only reflecting partial understanding, because the BiPAP delivers air. This can cause pressure support, but the statement my lungs to keep my lungs from collapsing, this is inaccurate, because the BiPAP can only do support breathing by improving the ventilation and oxygenation, right? We have a setting, right, that has already been ordered. It does not prevent lung collapse, which is not relevant to COPD or pneumonia. And the teaching focused on breathing support, not structural integrity. So it's not really reflecting full understanding. Now take a look into the next statement. The IV fluids are replacing what I have been drinking. Do you think this is understanding or no understanding? The answer to this is understanding, because this aligns with the teaching that IV fluids restore hydration, and also addressing the client's 24-hour lack of intake, and also signs like dry skin and also no urine output. So that's why that is correct. Now, what about the antibiotics are working with the mask to fix my lung infection? This is reflecting no understanding. The client correctly identifies antibiotics as the treatment for the lung infection, but linking them to the BiPAP makes it incorrect. All right. So the BiPAP cannot fix the lung infection. It does not have a curative role. It doesn't treat the infection. It can support the breathing of the client. Alrighty. What about the next statement? The mask is helping because my breathing rate is steady. Do you think this is reflecting understanding or no understanding? The answer here is understanding. Especially the purpose of the BiPAP. It delivers pressure to help with the breathing. And so the client connects it to a stabilized breathing rate, and also this indicates improved respiratory effort, and this also aligns with the teaching intent. So they definitely understood that their breathing rate, which is actually better this time at 24 breaths per minute. Now let's move on into our next statement. It says, the fluids will flush the infection out of my system. Do you think that this is a correct or statement or incorrect statement? Flush infection out of my system. This doesn't show any understanding at all. This misinterprets the IV fluid's role. So this is not going to flush the infection. This is only done to help the dehydration, right? Now, what about the antibiotics stop my coughing from getting worse? This is also a statement that reflects no understanding, because the client associates antibiotics with cough control, which is inaccurate. And the teaching stated antibiotics treat pneumonia. It's not going to really manage the coughing. And the cough may persist as the infection resolves. And this subtle misconception shows a lack of understanding regarding the antibiotics' role in treating the infection. And so that is the end of our Q&A today. I want you to pause for a bit to think about what you have absorbed and work on those practice scenarios. And I want you to continue growing your test taking skills. Now, if this video was useful for you, make sure to give it a like and hit that subscribe button for more NCLEX prep resources. And also give us a comment below to share how you did in this practice test. And I'll see you in the next video. Thank you for watching.